Good afternoon and welcome everyone to Columbia Neurosurgery on Facebook Live. We're so pleased to be here today during Acoustic Neuroma Awareness Week to speak with one of the leaders in the field, neurosurgeon Dr. Michael Sisti. Dr. Sisti is the James G. McMurdy Associate Professor of Clinical Neurosurgery, Radiation Oncology, and Otolaryngology at Columbia University Irving Medical Center at New York Presbyterian Hospital, and is also the co-director of the Gamma Knife Center. Dr. Sisti specializes in the treatment of complex brain tumors, meningiomas, and acoustic neuromas, employing state-of-the-art computer-guided microneurosurgery and gamma knife radiosurgery. During his 30-year career, he has operated on over 6,000 patients with these complex conditions and has pioneered many surgical and technical advances, including New York City's first non-invasive radiosurgery program. We are so pleased to have him here today to speak with us about acoustic neuromas. So welcome, Dr. Sisti.
Thank you. I'd like to say hello to everybody, Acoustic Neuroma Awareness Week. I'd like to tell everybody who might be watching this that you're going to be okay. In the 21st century, I know you can get a lot of information on the internet and from many sources, but the bottom line is, in this particular condition, this is a benign condition that really is about the quality of your life. The quality of your life we're most interested in preserving, either by watching you, by treating you with surgery, or various kinds of sophisticated radiation therapy, is to make sure that you can smile well, that you have good balance and equilibrium, and in some cases, if we're lucky enough, to preserve the hearing that is usually affected in this disease. I think in the modern era, when I see a lot of patients here in New York, and I've been principally involved both on the neurosurgery side and the radiosurgery side of treating patients with acoustic neuromas for 25 years, I've treated between radiosurgery and surgery over 1,000 patients with this condition and have several publications in this area. But I think the bottom line is my career has spanned the decades between where it was very difficult to diagnose one of these tumors. We didn't have CT scans, we didn't have MRI scans at the beginning. I was in medical school here at Columbia, New York City in the 1970s. There was only one CT scanner on this campus. I met most of my acoustic patients when I was in medical school in my residency in the emergency room with larger tumors and obstruction of flow of brain fluid in very difficult condition. I think a lot of patients are reading about those what I consider historical experiences on the internet now. The 90s were the decade in which everything changed in this disease. The very early part of that decade, we began to understand the genetic makeup of this disease, that it came from an insulating cell called the Schwann cell that wraps the balance and hearing nerve, which is the 8th of 12 nerves that are in your brain. And the definition of that to me is a schwannoma. I like to call it a neuroma because schwannoma doesn't really roll off the tongue very easily, is that's a benign and always benign condition. Does not grow rapidly, does not spread from the nerve in which it starts, does not involve other organs of the body. There are genetic conditions in which, unfortunately, some patients can have these on both sides. It's called neurofibromatosis type 2, and there's some variants of that. But the vast majority of patients with this rare condition have it just on one side. So we found in the 90s the ability to understand the genetic makeup of this disease. And then we got, most importantly, because I think most innovations in medicine come from the technological advances, which are incredible. And the big one that was the breakout in the 1990s was the advent of contrast MRI scans. Now, the contrast MRI scan, as early as the 1992, 1993, we began to see patients with minimal symptoms and really small tumors. I mean, like tic-tac-sized tumors. And we had never seen patients like this before because we had no way, really, of easily diagnosing these in the 70s or the 80s. So we began to see larger numbers of patients with minimal symptoms and preserved hearing as opposed to the patients who presented with really large tumors. Now, why do those tumors get so large? This is one of the slowest growing tumors that affects the human body. Doctors measure things in millimeters. They're 25 millimeters in an inch. So for those of you reading your radiology reports, which is fine, realize that if you have a tumor that's less than 10 millimeters, that tumor probably is just completely in your ear canal and is not even projecting into your brain cavity. When these tumors get to about 20 millimeters in size, which is 3/4 of an inch, maybe they touch the surface of the brain. And then when they get larger than an inch, they will deflect the surface of the brain. But the surface of the brain here, it sounds scary, the cerebellum and the brainstem, is covered by a very thick membrane. And because this tumor is encapsulated, it's very slow growing, what happens is the bones of your skull, which are very hard, your ear canal, push the tumor towards your brain, and the brain is slowly displaced by the tumor. And it takes years to develop a tumor, let's say, that requires surgery. So in the 90s, we got the genetics, we got the ability to resolve small tumors, then we got the understanding from the European experience, gamma knife radiosurgery, although many good radiosurgery systems, and in point of fact, they all work really well. In Sweden, a very well-known neurosurgeon named Lars Leksell had an amazing conceptual understanding of how radiation could be used to treat inoperable things in the brain. And believe it or not, in 1968, before CT scans, MRI scans, before computers, I believe it was January of 1968, and that's literally 50 years ago, Dr. Leksell did the first acoustic neuroma treatment at the Karolinska Institute in Stockholm, Sweden. The technology was advanced quite a bit by him and his team at the Karolinska, and the technology really became commercial in the early 1980s, with the first commercial machine being sold actually to England. Now there are about 300 gamma knives worldwide, and excellent work done here in the United States, mostly at the University of Pittsburgh, was able in 1998, 20 years ago, to validate the excellent results that the Europeans have been talking about for years, meaning the tumor is slightly less than an inch in size, 22 millimeters, that you could treat patients on an outpatient basis. No incision, no blood tests, no need for medications, generally in a single treatment session, that the vast majority of these patients, way high in the 90%, the tumor would stop growing or slightly shrink in size. Patients could immediately resume normal activities. And in some patients, hearing preservation was possible, but in most patients, again, high in the 90%, hearing preservation, facial nerve preservation, smiling, became routine. So in the 90s, we got the genetics, we got the ability to diagnose small tumors, and we got the ability to treat them, smaller ones, without surgery. In the operating room, we also made amazing advances, the biggest being the ability to monitor your brain function while you're under a special kind of anesthesia. So most anesthesia that you get, general anesthesia, your body is paralyzed, can't move your muscles. But in this particular surgery, if you have a larger tumor and there's a need to remove that tumor because its large size is causing symptoms, or your balance equilibrium, or pain in your face, or your other neurological functions, how do we know what we're doing in surgery is working for you? Are you smiling? Are you moving your arms and legs? Did you stick here? So in the 90s, there was an explosion of technologies that allowed us to monitor your smile. The instruments I use are connected to my patients directly through tiny little wires in their face. It goes to a computer that electrifies my instrument so that when I touch the facial nerve in surgery or get close to it, I actually have an idea not only where it is, but how well it's working. We can also monitor hearing in surgery, the function of other nerves, like for instance, how you move your shoulder or your tongue, and also how sensation is transmitted to both your arms and legs. So this ability, called neurophysiological monitoring, allowed us, using the most refined microsurgical techniques, to understand what we were physically, not only physically, but what we were doing functionally to patients when they're asleep, particularly with respect to their smiling, their brain function, and their hearing. And with advances in microscopes and microinstrumentation and neuromonitoring, I made the decision here at Columbia, because I had started doing radiosurgery. My background was in engineering. I was a chemical engineering major as an undergraduate community here in New York. It's kind of a tough road to go through medicine, but I think having an engineering background gave me a real perspective on computers and other analytical techniques, how to solve problems and work with people who have advanced technical backgrounds in physics and computer design and radiation. And I had the great fortune when I was here at Columbia that somebody that I went to college with was a radiation physicist, and we started a program of using a linear accelerator in the beginning to do radiosurgery. We treated the first patient here in New York in 1989. But in the beginning, we were learners, and we was mostly using this for patients with malignant tumors, like metastatic breast or lung tumors or clusters of abnormal blood vessels or inoperable. But really from the encouragement of the people around the world who were dedicated, not just myself, but many really skilled doctors in surgery and otolaryngology, ENT doctors, and radiation oncologists and physicists. All these doctors worldwide were seeing the same kind of changes I was seeing in the 90s. And this great network of world-class doctors got me thinking about what I was really doing for my patients. Was I trying to save their life? Was I trying to save their smiling, their hearing? And all the whole paradigm that I had been trained with in the 70s and 80s seemed not really to apply to me anymore. And I decided to become sort of a doctor with a foot in both worlds, a hybrid doctor. And in fact, to this day, it was 20 years ago in 1998, I did my first benign tumor treatment on Gamma Knife, and that was an acoustic neuroma. And in the last 20 years, we've treated over 600 patients non-surgically with this tumor, had a great experience with it, very similar to other people who have this amazing technology. I think that if you have a Gamma Knife and you know how to use it and use it as it's indicated, you get reliably excellent results, whether you're in New York or San Francisco or Tokyo. I mean, the technology is really incredible. And if you're a surgeon and you're used to doing surgery all the time and getting good results, it's really eye-opening when you use a non-surgical technology, you're talking to your patients, they're going home, going to work the next day, to see how effective this treatment is at maintaining the quality of their life. They're smiling. In some instances, they're hearing. And so I decided in 1998 that patients with smaller tumors, generally less than an inch in size, if they didn't have really bad symptoms like really bad pain in the face or really bad balance problem or twitching in the face or a really disabling equilibrium problem, the patients with small to moderate sized tumors, if they had a few symptoms, the usual ones being hearing loss or a balance problem, that I would treat those patients non-surgically. So I did my first one 20 years ago, and I haven't looked back since, and I've been able to ride the wave of Gamma Knife innovations in that period of time. The technology started out, as you can imagine, in the 1980s before MRI scans, and now it's evolved to essentially systems that allow us to treat patients without placing, those of you who are looking at the internet, you're seeing that head frame. The new variety of Gamma Knife called the Icon, it's the name of the new upgrade, allows us to treat patients without putting a frame on. And it works on a mask. This mask is not directly attached to patients. Our Gamma Knife here in New York sits right next to a subway stop, the AA train and the IRT. And I have patients who come in on a Monday morning and get this treatment. I allow them to get on public transportation and go back to work the same day. So I can show you what a mask looks like. So I know it looks a little odd, but this comes out of an oven as a solid sheet of warm plastic. We call it the Gamma Facial. We mold this to a patient's face. Your nose goes through here. You can see through this. You can breathe through it. It clips very securely on the machine. We actually put a little reflective dot on the tip of your nose. The machine looks at you 20 times a second. And if you were to move beyond the tolerance of, let's say, 12th of an inch, the treatment could stop. And this mask avoids the penetration of the pins that we used in the older days to affix patients to the Gamma Knife so you wouldn't move. We still can do that, and sometimes we prefer to do that. I've had a few patients that don't like the look of this and they're a little claustrophobic, and they actually prefer the head frame, which works perfectly fine. But this mask has been in the last year last year that we've been using it since it was introduced here, has been a godsend for my patients. I think they find this much easier to manage, and it gives us the option of doing the treatment instead of one dose of radiation and several doses of radiation. And theoretically, there may be some advantages to that for acoustic patients and hearing preservation. And this is not a new concept. Many patients who are out there maybe watching this will know about the CyberKnife, which is an excellent machine. We don't have one here at Columbia, but some of the other hospitals we work at, we have it. We principally use it to treat spine, and many places it's used to treat prostate cancer. But it has the same kind of physical particle that the Gamma Knife has, and so of course it's going to be successful at treating those tumors. But the interesting thing about the CyberKnife is the patient doesn't wear a frame, and the dose of radiation is usually could be given in 1, 2, 3, 4, or 5 individual treatment sessions. And in the last year, we've done a large number of acoustic patients who have hearing, which we're trying to save their hearing, which we've been breaking up the dose over a number of days. Of course, this is a new technology. We don't have long-term results yet, and because this is a very benign condition, it takes many years. It takes 10 years to really know what long-term hearing results are, although we have a very good idea 1 year after Gamma Knife, which your hearing is going to be like. In surgery, we have a really good idea the next day, but in Gamma Knife, it usually takes about a year to know where your hearing is going to be. So if you have preserved hearing now, we've now changed our paradigm yet again to go to the Icon mask-based system, and usually we're breaking up the dose in a few days with the object for patients who have hearing to preserve their hearing. And we're very hopeful. We don't know yet, but we're very hopeful that that we're now in the position for at least half of the patients I'm seeing here in New York, and of course, this is New York City, a lot of, it's America's largest city. We live in a very populous area with a lot of great hospitals and doctors here. And people who do this kind of work, we all understand we're not going to agree on how to treat this lesion. And the reason for that, this confuses my patients a lot. Like, why does one really good doctor with a good reputation and one really good world-class hospital want to do things differently than I do? It has to do with the rarity of this condition. So most studies have shown that if you just take 1 million people, in 1 year, about 20 people out of 1 million are going to come down with this condition. So if you think about it, here in the city of New York, it's about 9 million people. You're talking less than 200 patients a year who may be diagnosed with this condition. So how could we possibly get enough patients together to do, let's say, a clinical trial to look at the mass-based form of radiosurgery, the frame-based form of neurosurgery, what cybernetic protons, or whether we should do this by surgery, by roots going through your ear called the translabyrinthine, or going through the side of your skull called the middle fossa, or going through the back of your head, which is a hearing preservation root called the retrosigmoid approach. I mean, how would we ever collect enough patients over a long enough period of time to say that there's one right way to do it? And so, because we can't really do that effectively, although it's been tried, most doctors develop a practice of how they do things. And a lot of that is really, I think, the way I would describe it is medical culture. So I've been very fortunate that I've been here since 1977. So I started medical school here, I graduated college, and started med school here. I consider myself a token engineer in my class. That's how I got into medical school here. And so I think the Columbia philosophy is a first do no harm kind of philosophy, and I think that's why, as a surgeon, it was pretty easy for me with my technical background and how I'd been taught by my teachers and my colleagues to look for solutions that were not necessarily invasive. And so if you have an acoustic neuroma, what would I recommend to you or my colleagues here at Columbia based on how you come to see me might not be the same as another doctor with an equivalent experience as a surgeon, as a radiosurgeon, it's because my experience on doing this has been shaped by the time I've spent here as a medical student, as a resident, and this is my 30th year as an attending. And the way we structure here at Columbia is we ultra specialize. So I only do brain surgery and mostly benign tumor surgery. Our practice, I'm the principal surgeon that treats acoustic neuromas both with surgery and without surgery. And this is how, over the past quarter of a century, I've been able to get such a deep experience in this condition, given its rarity, because I work with some of the best neurosurgeons in the country, and you call Dr. Solomon, who's an aneurysm surgeon, you call Dr. Bruce, who's a pioneer regional pituitary surgeon, and you have an acoustic neuroma, they're going to say, I don't really do that kind of surgery, but I have a colleague, Dr. Sisti, he's right down the hallway, he does them every week, and really, if I had what you had, you really should see the doctor in any institution that's doing this as often as he or she possibly can. So I have, in our practice, almost 30 neurosurgeons. I have a lot of neurosurgeons who out there seeing patients and referring their patients to me, and I've been able to accumulate this experience in over 1,000 patients between surgery and radiosurgery in the last quarter of a century with this rare condition. But my way of doing it is sort of my way of doing it. It's the result of the culture of practice here at Columbia and what I found has worked and not worked in my practice. So let's just profile a patient. Let's say the things that I look at, first off, are the size of your tumor, the symptoms you have, and your age. So for instance, if you're 85 years old and you were scanned for no reason, like headaches or neck pain, or maybe somebody thought you had a mini stroke, and we find a tiny little tumor in your ear, whether you have hearing or not, that's probably the kind of patient I'm going to say, you know what, based upon your age and the known very benign slow growth rate of this tumor, that giving you radiation or surgery is probably not in your best interest. Now, if you've lost your hearing, there's really no point to treating you with a small tumor at that point in time. And I'm usually encouraging patients like that just to follow up with me with MRI scans. And the follow-up is really, it's like that Ronald Reagan thing, it's trust but verify. You should trust what I tell you, but we need to verify. The verification is the MRI scan. So we can make a prediction. If you're elderly and you have a small tumor, it's minimally symptomatic, I can be really encouraging that over the next couple of years, we're probably not going to see that tumor grow. And based on your age and the fact that every medical intervention carries some risk, maybe living with your tumor might be better for you and having me do radiosurgery or certainly surgery on them. Let's take another situation. Let's say you're a patient and you're in your 50s and you have a 2 centimeter tumor and you have some mild hearing loss, and you saw your ENT doctor. They did an audiogram, which is a test of hearing, and they found something interesting that, the hearing in one ear was a lot less than the hearing in the other. Now, most people, hearing loss is really common, but it's generally occupational or medical reasons. It's usually symmetric on both sides, meaning that if you lose hearing in one side from listening to loud music or working in a noisy environment, generally you lose the same amount of hearing in the other ear. But one of the red flags on an audiogram, if you see an otologist or an audiologist, and they say, we did this test and it's interesting, your hearing is a lot worse on one side than is another. That's a little bit of a red flag that probably you're going to see an ENT doctor or a neurosurgeon or a neurologist maybe, because this unilateral, one-sided hearing losses could indicate that maybe the problem is not your ear, that it's something in your ear canal or on your brain, and that kind of thing requires some kind of imaging, which in today's day and age is almost always a MRI scan because there's no radiation exposure in that. It can resolve really tiny tumors, especially with contrast. And so most patients who are coming to see me, because I'm a specialist, have generally presented just like this person. They have mild hearing loss or ringing in their ear, which is called tinnitus, which is a high frequency sound. And they've had an ear hearing test, and somebody, I'd say the unsung hero is the person who does the test and makes the referral for the scan, because it's kind of easy for me meeting you. You have an MRI scan, it's been read by a radiologist, you have your audiogram. I kind of know your diagnosis. There's really not a lot of question about that. But just imagine if you've been out there and this 20 people per million per year, and you've had hearing loss for a couple of years or some ringing ears. I'm going to tell you, your primary doctor or anybody that you're talking to, this is a very difficult diagnosis to make, just from your symptoms. And so many patients are disturbed by the fact that maybe they've had symptoms for a period of time. And I always say, look, you really should thank the person who ordered the scan for you, because without getting that scan, your neurologic exam, even your audiogram, it's very, very difficult to make this diagnosis. And I always say the unsung heroes here are the doctors on the front lines who listen to their patients and are curious enough and order the MRI scan and the audiogram and get the process rolling. The reason why time is not so essential is because this tumor doesn't spread. It really grows super slow, a millimeter to 1/25th to 1/12th of an inch a year. So even if you have symptoms for a little bit of time, this is not a cancer situation, so timing is not urgent to come and see me. So if you're anxious that you've had symptoms for a while and you've just been diagnosed, you're going to be fine. And from the time you had the symptoms to the time you get to the doctor, it's probably not going to dramatically change what we're going to recommend to you. So if you have a tumor, let's say 22 millimeters, and you have some hearing, and you're in your 50s or 60s, I'm very inclined to recommend radiosurgery to you. And why radiosurgery? It's because I think, a tumor that's that size at that age is not really life-threatening, other than the hearing loss. Well, the objective really is not only to stop the tumor from growing, but to try and save your hearing. So by using the icon gamma knife and breaking up that hearing dose, the radiation dose over a couple of days, we think currently, and we'll find out hopefully in the next 3 to 5 years or longer, that this is a better way to try and save hearing who have small to moderate sized tumors and minimal symptoms, who are sort of in the mid to older years of life. That's what I would have. I see neurologists and neurosurgeons with this, and many patients are about my age, and they've done their research. They ask me, will my radiation give me cancer? And it's a very common question, good question, because we know radiation can cause cancer. But I'm saying, look, the radiation is only going to this tumor. These tumors are very small. If you thought of them as a three-dimensional object, they're usually on the order of like a domino sugar cube, between 1 to 3 or 4 of those. So the radiation, the way it comes at you from 200 separate angles, the actual dose to the normal structures is really, really low. And the dose to the tumor is almost always enough to kill it. I mean, it's rare in neurosurgery to say it's going to work 98 to 99% of the time, but that's how often it works. And so radiation, cancer-induced radiation also depends upon the amount of time that goes on from when you're exposed to radiation when you get it. And I have a practice in radiation-induced tumors, mostly children who were radiated for various reasons when they were younger. They're now surviving as adults. Or doctors and dentists who work around radiation all the time don't take precautions, 2 particular examples. But if you look at those patients and how they got the radiation, how long it was given, I mean, the time that tumors show up, it could be 30, 40 years. So look, if you're 8 years old and you're thinking about radiation, it's a whole lot different than when you're 58 years old. So I generally try and reassure my patients based upon my experience and, the long track record of gamma knife going back experimentally to the 60s and commercially the 80s, that that's really not a significant consideration. I also tell patients, because I'm a surgeon, look, there's a failure rate to gamma knife, and I've had 7 patients over the last 20 years. On the larger side, usually older patients with serious medical problems, particularly people on anticoagulation, with heart disease, so on and so forth. Patients who are not good risks for surgery. I generally said, look, maybe your tumor's a little bit on the large size for gamma knife, but this is a benign condition, so maybe we should try a non-invasive approach first. And I've had 7 patients actually that have failed that. And those patients have all gone to surgery. And I keep hearing a lot from my patients that, gee, Dr. Sisti, doesn't it make surgery more difficult? And I would say, I think it depends upon the experience of your surgeon and the goals of surgery. I personally have not found it more difficult the way I do the surgeries, and maybe it's just been here a long time. And I'm not particularly aggressive in these surgeries when it comes to the brain or the facial nerve for sure. So I'm always telling patients, look, if the gamma knife doesn't work, and you're one of those rare patients, 1 in 100 or so, then I'll take care of it for you surgically. One interesting thing I've never done, and I'm still waiting to do, is I've never done gamma knife twice on a small. So some centers that have had bigger experience than myself, particularly European centers, if you have a small tumor and it doesn't work because the dose radiation is so low, you can repeat it. Like in our cancer practice, we repeat it all the time in multiple sites and single sites. I've never actually done gamma knife twice on a small tumor. I'm still waiting. I guess I'm overdue. I always tell my patients, don't be that patient. But if you had a small tumor, like you had an 8 millimeter tumor, and it went to 12 or 14 or 15 millimeters, I certainly would consider a second dose of radiation. Just never had to do it. So I guess sooner or later it'll happen to somebody. It's just the nature of being, human being, and the kind of conditions we treat. We can't really control that. We don't want it to happen, but it does happen. But if the tumor's on the larger side and a second dose of radiation really wouldn't work, then I don't really have an issue operating on patients like that. And I tell them, don't worry, we'll get you through it. You'll be okay. So the surgical side, of course, is the scariest thing. And generally, the average size tumors I'm operating on are about 34 millimeters in size. That's a pretty big tumor. It's too big for radiosurgery. Patients like that have been growing their tumors for 10, 15 years before they get to me. If you're one of those patients and you have a scan, you see that large white circular object by your ear in the back of your head. I know without a biopsy, all doctors do this, that the only way you get a tumor of that size and be as functional as yours, it's benign, it's separate from your brain, it's been growing slowly over many, many years. It's kind of a paradox. The bigger the tumor and the better shape you're in, probably the more likely that's a benign tumor. But a tumor that's that size can be treated with radiation safely. That would be more radiation to a bigger lesion, and it could be more swelling. Patients generally present with symptoms. Radiosurgery is not as good at dealing with symptoms like bad facial pain or numbness or twitching in your face or a balance problem. In surgery, you're physically removing the mass of the tumor. So most of the surgeries I'm doing, whether you have hearing or not, I'm usually entering from behind your ear. It's called the retrosigmoid approach. I don't shave hair in my surgeries. I always fill the bone in to prevent postoperative headaches. And I tell patients preoperatively, look, the goal of this surgery is as follows. It's my basic goal for the surgery is to remove enough of that tumor in one setting, a big one, so that you only have to have one surgery in your whole life. And then secondly, I want you to wake up and smile with me when you wake up after surgery in the operating room. So I go tell your family, I got the majority of your tumor out, all of it out, and you're awake, you're talking, you're moving, and you're smiling. And then I really like you, because I mostly do these surgeries on Tuesdays and Wednesdays, I really like you to go home on the weekend without physical therapy or rehab. I mean, you have to say my dream goals. It's one and only one surgery. It's a beautiful symmetric smile and no physical therapy or rehab. And that's what I'm thinking about in surgery. And this is where the radiosurgery part of me comes in, because there's a point in a big tumor surgery, a really big tumor surgery, where your tumor is going to be small enough that I've met you, I probably would not recommend surgery to you, or maybe not recommend anything at all. So if we get down to the point where the computers are telling me in surgery, hey, Dr. Sisti, that facial nerve looks good to you, but you have to keep turning up the current to make your patient smile, or maybe the sensory disturbances in the legs or the arms are indicating how the brain's moving is not good for you, well, then surgery's over. Then I I don't really perceive this as I'm trying to save your life, I'm trying to save the quality of your life. And if we've reduced the tumor to a size where we can watch it, which I usually prefer after surgery, or radiate it, then I prefer to do that. So since my surgical practice is a practice of really large tumors, a fair percentage of my patients will leave the surgery with small pieces of the tumor left behind. And those pieces are left behind to preserve brain function, smiling function, principally, sometimes hearing function, occasionally sensation function in the face. Sometimes those pieces of tumor are so small, they're difficult to resolve on the MRI scan, but sometimes they're larger. And I always tell patients, look, we don't need to rush you to radiosurgery. Let's let you recover completely. And then I generally like to watch my patients with MRI scans. I usually say 10 years worth because it's such a slow growing tumor. It takes a long time to really know what the long-term results are. And if my perception of your tumor, not necessarily the radiologist's perception, says, hey, I think that tumor's growing back, then of course you don't have to have a second surgery. You can have, if you don't have hearing, you can get the icon gamma knife in one single treatment. It's a one and done treatment. If you do have hearing, we probably use the mask and then break it up over a couple of sessions of treatment trying to save your hearing. The hearing in surgery to me is the one thing that I always discuss last with patients because it's the one thing that's least controllable by the surgeon. And there's a good biological reason for that. The nerve of hearing is not like your facial nerve. So everybody probably knows somebody's had Bell's palsy, and usually a viral infection or a cold or some other reason, and you can't smile on the inside of your face, and then over a period of time, the facial nerve actually regenerates itself. So the facial nerve has regenerative capacity, but its next door neighbor, the hearing nerve, is really like, it's made of the same kind of cells that make up the cells of your eye, optic nerve, your spinal cord. The hearing nerve is actually part of your brain if it's in your ear, and it can't regenerate. So any damage to the ear, like for instance, if you come to me and you have hearing loss, that hearing loss isn't from your ear, it's actually from your brain. That's where the tinnitus comes from too. So although the hearing nerve is larger than the facial nerve, and I frequently can save it as a structure, it's like trying to save the function of a piece of brain tissue. There are a lot of variables that are not up to you, your surgeon. How stuck it is to the surface of the tumor. What's its blood supply? Is the blood supply being shared with the tumor or your brain? And so there's some small subset of patients that have a type of acoustic neuroma in which I would say everything's perfect. A larger tumor, the cochlear nerve, the hearing nerve, the eighth nerve is not very stuck to the tumor, it has its own little independent blood supply. And that kind of patient, even though I say it's the miracle zone, I'm only trying in that patient to do two things. One, to save that nerve, and two, to save the nerve's function. Save the nerve's function to me, you have to be able to use a telephone. So functional hearing is very hard to do in tumors in the 3.5 centimeter size, but every now and then it's possible. I use Louis Pasteur's line, chance favors prepared mind. You come to me with the right set of circumstances, we get a little lucky, I do my job, and maybe we pull off that miracle. But even if we don't, leaving the nerve does leave the option, doesn't happen very often, to think about MRI-compatible cochlear implants or other kinds of things. And I work with excellent ENT doctors who specialize in hearing supplementation or augmentation. And so if the nerve is physically intact and present, even if it's not working, there could be some options for hearing supplementation, particularly now with MRI-compatible cochlear implants and other things. So something to think about anyway. The thing about this disease is that it's a benign treatable condition and it requires a long-term commitment between the doctor and patient. I follow my average patient at least 10 years. And when you're looking for a doctor in a hospital, the key thing to ask is, what's your experience in doing this tumor? Do you do your own radiosurgery? Do you do your own surgery? Do you do a little bit of both? And then another important thing is, what have you contributed to the field? Have you collected the information of your surgical results and tried to put it in a peer-reviewed journal? So this is hard to do, obviously, because to accumulate enough patients to make something new about this condition that's been known for a long time is difficult. So it takes many years. In my case, in 1998 to 2008, I accumulated well over 400 patients, of which about 380 or so I published in Journal of Neurosurgery in November of 2011. I'm talking about this, that if you had a smaller tumor, I was inclined to radiate you with the gamma knife. Then we had the frame-based system. And if you had a larger tumor, I was more inclined to operate on you, but leave a piece behind if I was going to save some kind of critical function like you're smiling. And then if that residual piece grew, I would treat you with a gamma knife. And so that paper's been out there for a long time, and I just did an update on the rarer tumor that occurs here because there are really only two tumors that occur here, the acoustic neuroma and the meningioma. Meningioma is more difficult, unfortunately it's rarer, it's about 2 per million per year. And in the December issue of the 2017 Journal of Neurosurgery, we had the cover issue here at Columbia, which basically, as an illustration, tried to espouse my philosophy. And I'll decode this illustration for you. So what I wanted to emphasize was it was really about the patient's face and the facial nerve. And that's why 2/3 of this picture, you see this person smiling and these yellow lines here are her facial nerve. And then these little blue, this is the tumor in outline here. And you can see the little piece of the ear canal where these tumors originate, these little blue lines from the top, that represents radiation from the top. And below, you can see the larger part of the tumor that's pressing into the brain. This is sort of a representation. This is meningioma. Acoustic neuromas are easier because they're less vascular and they're not lumpy on the surface. But you get the idea. Here's your brainstem. Here's the facial nerve going over the surface. And so sometimes if you've got a tiny little tumor, you could get radiation from above. You get a really big tumor, you can get surgery from behind, or sometimes you get a little bit of both. But really, we don't really want to emphasize sort of the technical part. We really want to emphasize the patient. What do you feel like? What do you look like after the surgery? I mean, we're doing this, to make sure that the quality of your life is as good as it can possibly be, and that you have the least amount of interventions by us. And so, this photograph, this illustration is on the cover of the Journal of Neurosurgery, sort of expresses my philosophy about treating tumors in the cerebropontian angle, of which acoustic neuromas and meningiomas make up about 95% of the tumors that I do here. Unfortunately, this one's a lot rarer than acoustic neuroma. So I think when you're talking to your doctor, I think it's very reasonable to ask about your doctor's experience, how much have they done, what's their experience with various kinds of radiosurgery. I don't think the type of radiosurgery is that important. This tumor is very sensitive to radiation. I think if your doctor's using proton or cyberknife or linear accelerator gamma, I think it's all good. This tumor is just really sensitive to radiation, but you have to have some familiarity with it, how to deal with the issues and follow patients up. Then, of course, who's in the OR, what's the surgical team, what's your philosophy about monitoring, what's your philosophy about follow-up, and I think those are really important because unlike some patients with more aggressive conditions where their follow-ups will be shorter, or patients that have other kinds of benign tumors that are not as critical areas of acoustic neuroma, this really requires a long-term relationship. And even if the tumor is completely removed and you're perfectly fine, how do I really know I got every last microscopic cell? It's such a slow-growing tumor. I usually recommend 4 MRI scans over a decade in a person with a complete resection. And maybe somebody with an incomplete resection will get more scans. And radiosurgery, generally, it's still about 4 scans over a 10-year period. So, there'll be some phone calls, there'll be conversations, visits. Really get to know my patients, and it's been a pleasure to take a really scary thing and help to decode it to something that's manageable and has reliably good outcomes for patients. And of course, as my teachers told me, anybody can be a nice, easygoing doctor when everything is done exactly the way you want. But what happens when there are problems? And of course, in radiosurgery and in surgery, there are always issues. It's never as easy as I or a patient thinks it is, and every person has their own way of going through it. So, your doctor needs to know how to handle all issues related to this. Your headaches, the possibility of accumulation of brain fluid underneath the incision. What if there's some symptoms 6 to 8 months after radiation from a slight degree of swelling from the radiation? How do you interpret the scans? How do you work with your ENT colleagues or your radiation oncologist? I mean, I think the mark that distinguishes the master or the expert doctor from just a really good one is not the good result. It's when you have issues, is your doctor going to be able to explain things to you, get you to the right doctor, to answer your questions, and hang in there with you and solve your problems. And so fortunately, in this particular condition, that doesn't happen very often, but anybody who does this surgery or does it to any degree like I have always has a patient. I say, your tumor didn't read the book. And I'm not saying that you would be that person, but if you're that person, we'll be there for you. We'll just do whatever we have to do to get you through it, make sure you and your family members understand what's going on, solve your problems. Fortunately, unlike many of the other conditions I deal with, this one has the least degree of problems, I think, in my practice. But if there's an issue, we'll be there for you and we'll help you with that issue. And if I can't help you, believe me, I work in a place where so many experts, I'll find somebody who can help me to help you. And I think that's what you need to know in this condition. So thanks for listening in. I know I droned on for a while. I have a tendency to do that, but it gives you sort of a flavor of who I am and what my thinking on this is, what my experience is, where I work, what kind of technology I have access to. And, for me, Mondays is a Gamma Knife day, Tuesdays is an OR day, and sometimes it's a little bit of both. But I've been very privileged to work at a world-class medical center in a world-class city my entire career, working with the best kinds of people, the most interesting patients, I think. And it's been a real privilege, great teachers, and I have great students. If you come here, you'll see what a special place this is and how fortunate I've been to be practicing here my entire career. Thanks.
Thank you so much, Dr. Sisti, for taking time out of your busy day to speak with everyone here on Facebook Live. For everyone watching, the full interview will be available on our Facebook page shortly after we're done, so please feel free to go back and watch anytime at your convenience. For more information about Dr. Sisti, acoustic neuromas, or neurosurgery here at Columbia, please visit columbianeurosurgery.org.